Hello everyone. Today we'll learn about right bundle branch block, left bundle branch block and fascicular block patterns that are seen as an abnormality in ECG. In right bundle branch block, the first phase of ventricular depolarization that generally is initiated by left bundle branch, and the vector points towards the right side of the heart from the left side of the heart is not affected. The second phase of ventricular depolarization is also not affected because of the dominance of the left side of the heart. The vector points towards the left precordial leads. But even after the depolarization of the left side of the heart, the right side continues to depolarize because of the blockage of right bundle branch, and this gives a third phase of ventricular depolarization in right bundle branch block. When this pattern is traced on ECG, we get an R, S, R dash pattern in lead V1 and Q, R, S pattern in lead V6. Now this R is greater than 1 to 2 millimeter of height. Okay, and this complex, the QRS complex, is greater than 0.1 milliseconds or 0.1 seconds or 100 milliseconds. Okay, so if there is a narrow QRS duration and there is a very small terminal R wave, then the RSR pattern is a normal variant. It is not because of right bundle branch block. So right bundle branch block can be more seen in right precordial leads V1, V2 and V3. As we can see, there is an RSR pattern in lead V1 and in the right precordial leads, and it is associated with secondary T wave inversions. This secondary T wave inversions is generally seen in right precordial leads. Now it should not be confused with a similar pattern that is seen in Brugada syndrome. Brugada syndrome is generally associated with increased risk of ventricular arrhythmias and sudden cardiac death. In Brugada syndrome, the RSR pattern is also associated with an elevated ST segment. Okay, that is not seen with right bundle branch blocks. So the right bundle branch blocks can be complete and incomplete based on the duration of the QRS complex, and it can be associated with various anomalies or various disease or pathological process. First of all, the right bundle branch block can be seen as a normal variant. Okay, so right bundle branch block does not always need intervention. Okay, beside normal variants, it can be seen in various other pathological state as mentioned in the presentation. So now we deal with left bundle branch block. Since in left bundle branch is blocked, the time for depolarization is increased, and the first phase of ventricular depolarization, in which the vector normally points from left to the right side, in this it points from the right to the left side. As a result, we see a first negative deflection in V1 and a first positive deflection in V6. Okay, and subsequently, because of bundle branch block, the second phase of ventricular depolarization is also prolonged, and that is why we have a wide QS complex in lead V1 and wide R complex in lead V6. Okay, so lead V1, I think, is the best way to differentiate between left bundle branch and right bundle branch block. In right bundle branch block, we will have an RSR pattern. In left bundle branch block, we will have a wide QS complex. So in left bundle branch block, we can see a wide QS complex. Okay, wide QS complex, and in V5 and V6 we'll see wide R waves, and there is a typical notching in this R waves and in QS waves, and this is called as W pattern in V1 or the right precordial leads, or M pattern in the leftmost precordial leads like V5 and V6. That is typical feature of left bundle branch block. as seen in the right bundle branch block. Secondary T wave inversions also seen in left bundle branch block as in the leftmost precordial leads, like we can see here in V6 and we can see here in V5. So right bundle, left bundle branch block can also be complete and incomplete based on the duration of the QRS complex. Remember, left bundle branch block is rarely seen in normal individuals and is usually a sign of organic disease and is associated with various anomalies. Okay. If there is a left bundle branch block, left ventricular hypertrophy should be thought of, because it is most commonly associated with left bundle branch block. There is something that needs to be added. If, as we know, the right bundle branch block and the left bundle branch block has a wide QRS complex, so in certain situations the ECG tracing might show a wide QRS complex, and the differential of wide QRS complex includes ventricular arrhythmias, WPW syndromes, pacemaker rhythm, left and right bundle branch blocks. But in certain conditions we will not have any of this pattern seen on ECG, but still the QRS complex will be prolonged or will be more than 0.12 seconds. In such cases we can thought of other organic disease like myocardial infarction of anterolateral wall of the heart. Okay, and this is referred to as interventricular delay. This pattern is referred to as interventricular delay. Now this is how we can differentiate between right bundle branch block and left bundle branch block. We can see here the RSR pattern, okay, and we can see here QRS pattern, okay, in V6, and we can see wide QS complex and wide R complex in V1 and V6 respectively, with the typical notching feature that is seen in left bundle branch block. Okay. Then we come down to fascicular blocks. As we know, left bundle branch divides into anterior fascicle and posterior fascicle. The fascicular blocks does not widen the QRS complex. The bundle branch blocks widen the QRS complex. The left anterior fascicular block is associated with marked left axis deviation, while left posterior fascicular block is associated with marked right axis deviation. Now, left posterior fascicular block is a very rare event, okay, and it should be considered only after other causes of RAD has been excluded, like right ventricular hypertrophy, emphysema, lateral wall MI, pulmonary embolism, or other normal variants. So there is a new concept emerging that instead of calling it as a right bundle branch and left bundle branch, we can call it as a fascicular system. Left anterior fascicles, left posterior fascicle, and the right fascicles. That is, right bundle branch is called as right fascicle. So a bifascicular block indicates blockage of any two of the three fascicles. So the risk of complete heart block in asymptomatic patients with chronic bifascicular block is relatively low. So if the bifascicular block is an acute, then it carries a poor prognosis and has a higher risk of developing a complete heart block. So this is one of the examples of bifascicular block in which there is a right bundle branch block associated with left axis deviation. As you can see, tall R waves in lead 1 AVL and deep S waves in foot leads like 2, 3 and AVF, denoting left axis deviation. Okay, so this is right bundle branch block with left anterior fascicular block, and this is right bundle branch block with left posterior fascicular block. In this condition you can see a right bundle branch block, the RSR patterns in right precordial leads, and a right axis deviation. In right axis deviation, the foot leads will have heightened R waves, and the lead 1 AVL will have deepened S waves. So these are the two examples of bifascicular block, how the tracing look like. Thank you for watching.